Good afternoon and a very warm welcome. Fantastic to see so many particular speech therapists attending today, so welcome. So today's webinar is all about managing speech issues and communication, swallowing issues for people in progressive neurologicals. We're very fortunate today we've got Fiona Walsh presenting for us, and I'm your facilitator, Nicola Graham. Just briefly, some housekeeping. We've sent the handouts to you. If anybody has booked in late and hasn't received their handouts, please let us know and we will make sure you receive those. And just a little bit of information about your control panel. You will all have an orange arrow as per here, and you can maximize or minimize your control panel with the orange arrow. If you maximize it, then it gives you the opportunity to type in questions here, and I will see those questions and I can interrupt Fiona and ask her as appropriate, and we would love you to put questions in, so we really encourage you to ask questions as we go along. So I'd like to start by acknowledging and paying respect to the traditional custodians, past and present, on whose lands we meet today. And we acknowledge the deep feelings of attachment and the relationship of Aboriginal people to country, and respect the cultural authority of the elders in each community. So as mentioned, today we're fortunate we've got Fiona Walsh here. Fiona's a speech pathologist working at Calvary Care, Bethlehem, and she's been there just over 5 years. It's a statewide level 5 progressive neurological disease service here in Melbourne. Fiona's speech pathology role includes provision of inpatient, outpatient and domiciliary assessment, management, education, as well as participating in the specialist VFSS clinic. And Fiona, I did mean to ask you what VFSS is.
It's a video fluoroscopy swallowing study, so x-rays of swallowing.
Okay, great. And also Fiona provides specialist secondary consults to other speech pathologists, as well as liaising with local speech pathologists in the joint management of people with progressive neurological disease. So just a point here about informed choice. And then I'm handing over to Fiona for the presentation. Thank you.
Thank you, Nicola. Welcome, everyone. As Nicola has mentioned, today's webinar is called Speech Pathology Management of People with Progressive Neurological Diseases. A very broad topic, as I'm sure you can see. So I'm hoping that everyone will get a very broad overview of some of the general concepts, as well as some more specific ideas when working with people with a progressive neurological disease. Today, the main aims will be to cover the principles of care when working with people with a progressive neurological disease, symptom management in this area. That's covering communication, swallowing, as well as secretions. Briefly looking at, AAC in the realm of people with PNDs or progressive neurological diseases. And then we might have a little think about the challenges facing us when working with people with progressive neurological conditions. As Nicola has mentioned, you do have the opportunity to ask questions, so please do. We can either build this into the session, or else alternatively at the end we can do a bit of a Q&A session. So just a bit of an overview, I guess, of where I'm coming from and the lens through which I'm viewing things and how things will be presented today. As Nicola said, my name is Fiona. I work at Calvary Care, Bethlehem, which some of you may have heard of and some of you may not. It is a level 5 statewide service provider for people with progressive neurological diseases. We are based in Caulfield in Melbourne, but we service the entire state, and we're very fortunate to have a big multidisciplinary team there that we work with, comprised of the medical side of things, so the doctors and the nurses, and we've got psychiatry. We also have a large and extensive allied health team composed of physiotherapy, occupational therapy, speech pathology, dietetics, clinical psychologists, neuropsychologists. And we also have some of the, I guess what we call psychosocial type disciplines, such as pastoral care, social work, music therapy. So very fortunate, and we all work very closely together, which really does have, we think, very good outcomes for people who attend the service. So that's enough about our service. The types of people who we see, the main bulk of our patients are people with motor neuron disease or Huntington's disease. We do see some other types of progressive conditions such as spinocerebellar ataxias or muscular dystrophies, myotonic dystrophies. We see some people with advanced and complex MS, as well as advanced and complex Parkinson's disease and the Parkinsonian syndrome, such as PSP, which is progressive supranuclear palsy, or MSA, which is multi-systems atrophy. We see a bit of inclusion body myositis, as well as a handful of other very rare conditions. So, working with people living with progressive neurological diseases, some of the principles of service that we at Bethlehem aim for are that the service really is person-centered. So there's no one size fits all. It's about the individual and what their needs are, and even though everyone's journey might have similar aspects, their needs will always be different during their journey. We strive for an equitable service or equitable access to care. That does not mean the same care for every person, but it means that everybody is entitled to access the same level of service and the same care when they need it or if they choose to. Another principle of service that we aim for is to provide skilled or specialist support. We know that people with progressive neurological diseases request and appreciate knowing that they are working with a skilled team and people who have specialist knowledge to support them, and that this care is provided in a team-based fashion. Specifically, a multi or inter/transdisciplinary care is provided, and that's a really important principle of service, that it's not just neurology, it's a whole team and we're all working together and communicating together. Some of the general points, I guess, are when working with people with a progressive neurological disease is that you do need to have an understanding of the prognosis of this person, and that's really going to inform whether your intervention is going to be of benefit. So knowing what their disease trajectory is, knowing what their prognosis is, and using that to decide whether what you do is going to be beneficial or not. You need to understand as well and be comfortable with the fact that it's a changing condition, and the nature of it means that, you know, it's not static, it's going to change. And this is particularly important when we're considering equipment or, I guess, strategies to compensate for things. Is the investment going to be worth it? And again, we need to be preempting and thinking ahead. Things are going to change. Is this the best way of doing things, or do I need to build in some contingencies for when things do change down the track? It's important to, I guess, I say don't shy away from uncomfortable topics. So in the world of progressive neurological conditions, we know that people will be changing, function will be deteriorating, and often it's, you know, we can perceive this as an uncomfortable topic or something difficult to talk about, and we might not want to upset a patient. However, feedback from patients suggests that it's actually us that's more uncomfortable with this than they are, and they really want to know. They have a right to hear the information and to hear what we know. Whether or not they choose to accept that is different, but we need to tell them. So, you know, just because somebody is, I think, going to lose their speech doesn't mean that I don't bring up a topic of voice banking with them because I think it might upset him to think about losing his speech. I can say something like, I know it might be difficult to talk about, but voice banking is an option for if people lose their speech. Is this something you'd like to talk about? And they can then choose yes or no. But I can't avoid that conversation because I think they might be upset. And quality of life is always really important when working with people with progressive neurological diseases, and balancing that up with safety and risk. And I think when working in other spheres, we can become very focused on safety, but with people with progressive neurological diseases where ongoing loss of function is a reality, we need to really bear in mind quality of life and maintaining that. And we have the responsibility to educate the person with a progressive neurological disease and to empower them to have ownership and to be an active member in the management of their disease, of their condition. And the final point really is that when working with people with progressive neurological diseases, it's important to have a wide, holistic view. It's not just that person that's affected, it's their whole family and friend and social network. And we really need to bear that in mind and make sure that our management involves all of these important people also.
Fiona, I've got a request here for you to reiterate that beautiful way that you brought up speech banking, because I think it was such an eloquent way of
I'll go back. So what I find helpful to say is, I know it can be difficult to think about this or talk about this, but voice banking is something that some people choose or can be an option for someone. Is this something you would like to talk about today?
That's great. I think there's somebody out there avidly scribbling back down to use again.
It's okay. It's different every time it comes out, but it puts it out there. This is an option. Would you like to talk about it today?
Yeah.
And even using the word today means that maybe not today, but maybe next time. It's an ongoing conversation. I have a quote here. This is a slide I've stolen from one of the doctors, Dr. James Howe, who's a neurologist at Calvary in Bethlehem. It's by a neurologist called Matthews, who is apparently a very eminent neurologist. And the quote is, "The best test of a physician's suitability for the practice of neurology is not the ability to memorize improbable syndromes, but whether she can continue to support a person with motor neuron disease and keep the patient, the relatives, and himself in a reasonably cheerful frame of mind." Some of the pink bits there are a little edits made by Dr. Howe. I think he's trying to keep it gender balance there. But really, what's at the crux of this is the fact that a progressive neurological condition is incurable, but it's not untreatable. And that's what our role is. It's a problem-solving approach to treating what the symptoms that arise. There's no one answer. It's different for everyone, but we can make a difference. And in fact, a multidisciplinary approach has actually been shown to improve survival in people with motor neuron disease by almost 8 months compared to a general neurology clinic follow-up. So that's, I think, a very powerful point to remember. Just because it's incurable doesn't mean it's untreatable. Which brings us on to symptom management, specifically in the role of dysphagia. When you encounter someone with a progressive neurological disease, the first thing we're going to do, as with everyone, as you all know, is to do a thorough assessment. So you're going to take a really detailed case history by the patient and or the carer. So often I get couples coming in and the patient will say one thing and their husband or wife will say, well, actually, this happens or that happens. So it can be good to get both aspects. I ask about, do people avoid anything? Because often people don't realize that avoiding things is a sign of a dysphagia, particularly in a progressive condition where they might gradually be noticing changes and gradually be cutting things out. You do your clinical bedside assessment and your observation of swallowing, as you always would, and then considering, is a video fluoroscopy indicated in this? And some of the progressive neurological conditions might be associated with silent aspiration, where a video fluoro could be good. A video fluoro can also be really good for education and giving those people that bigger picture around dysphagia. I often like to provide education to people around what the likely expected changes are. So I guess within that context, though, I mean the next change. So for example, some people might find that it gets harder to chew food, or some people might find it gets harder with dry or crunchy food, so that people are aware of what to look out for, what can be the next change that they should be alert for, and then also give them strategies to implement. So for example, you might find that dry food starts to get a little bit more difficult. A lot of people find it helpful to put sauce onto their food, something like that. So that people are preemptively armed with what to look out for and what to do. I always reassure people that my job is to make sure they maintain oral intake in a way that's safe and also enjoyable. My job as a speech pathologist is not to put people onto modified fluids or make them nil by mouth. It's to make sure they continue enjoying eating and drinking. And I find that presenting things in an all or nothing type fashion, such as you are not safe to have red meat, is not helpful. My role is really to provide alternatives and to provide information, and to try and do this in a positive light.
And Fiona, is that careful tightrope between risk and quality of life?
Yeah, I actually have a bit of a slide on that I might talk to further down the track. It's absolutely about balancing up risk and quality of life, and that balance is different in people with progressive neurological conditions compared to someone who's had an acute event where, for example, they've had a stroke and safety is the initial concern. In this, because you're having progressive and ongoing loss of function, people know they're going to keep losing function, so we need to really bring quality of life to the fore. Eating is a social activity. It's not just something that we do to sustain ourselves. It's really, you know, think about when we eat. There's Christmas meals, there's family dinners and breakfasts. It's really about getting together and celebrating. And when people lose the ability to eat, they lose often the ability to participate as they would like in these, you know, social gatherings. So when we're giving advice around dysphagia management, we need to make sure that it's addressing the broader scheme of things. So for that exact reason, that's why we need to involve family in discussions and family in strategies and education. If we want a person with a progressive neurological disease to be supported in implementing strategies, the family need to know what those strategies are and why they're using them, and that the aim is that this person maintains a quality of life. I personally find it very important to acknowledge the loss around dysphagia. So, yep, I know it's really hard. You can't go to the pub and eat that parma with your mates anymore. That's hard. And provide emotional support and to be sensitive around that, not just hammering home the safety message the whole time. There is loss there, and we do need to acknowledge that. Strategies, not doom and gloom. So you need to, you know, provide education around upcoming expected changes, what to look out for, but provide people with alternative options or strategies or adaptations presented in a really positive light. You know, people are aware that they've got a progressive condition. People are aware that they were losing function and will continue to lose function. They don't need me to tell them that. What they need me to tell them is, what can we do instead? So some people find it, yes, you're really struggling with your tablets. Some people find it really helpful to have tablets in a pureer. Some people find it really helpful to have their medication in an alternative format. It just takes the work out of it. What you're doing is you're presenting a change in texture or something in a positive light, as solving a problem, as making things easier. This is, I guess, a much more helpful strategy rather than focusing on what's no longer safe. So rather than saying you need a soft diet, you're no longer safe to have your steak, putting things in a way of, oh, okay, I can see it's taking you a whole lot longer to eat, or it doesn't sound like it's very pleasant at the moment. Lots of people find it helpful to put a sauce on their food. Lots of people find it helpful to have softer veggies. It takes the work out of chewing, and it can be a lot easier that way. So trying to present your strategies as a solution, as something positive. Remember that the person has a progressive condition. They've got the progressive neurological condition, and they're living with it. They're aware that they're going to continue to lose that function. So I really advocate strongly for changing really only when it's needed. So changing any sort of strategies, any diets, really when it's needed. So people tend to go as long as they can with what's quote unquote normal. I'm not tend to be resistant to any change. If I don't want to get people offside, I need to make sure that my recommendations are matched to that. So, you know, don't suggest somebody requires modified fluids too soon unless it's actually really needed. Is there another way around it? Can a person manage with strategies? And even if it looks less than ideal, that person might continue. Person might not be ready to change. They might not, you know, follow our recommendations. So as part of that, I like to provide education, of course, around safety, but also kind of harm reduction management kind of built into my practice as well. If I'm giving suggestions, if somebody thinks is better with modified fluids and they're resistant to that, you can say, you know, can we do things like, how about they have their tea and their cordial in the morning, and then when you're tired in the afternoon and the coughing starts, you might be more comfortable comfortable having the thickened fluids in the afternoon. So it's not, again, it's not that all or nothing. You're providing solutions to a problem. This is what you were alluding to, Nicola, is that it's that real balance between the dignity and the risk. And I think we as speech pathologists focus very much and very often on risk and on safety, and rightly so, but particularly in the realm of people with progressive conditions, we need to have dignity or quality of life very much at the fore of our mind. And we talk about this principle of dignity of risk, and that's a principle that really outlines the freedom to make decisions and choices, even when that might expose a person to a level of risk, and it allows an individual the dignity to make a choice, and that really does enhance their quality of life. And lots of people talk about, well, we've got a duty of care to their safety, and in fact, you know, our duty of care should not just be about keeping people safe at the cost of their other rights. Our duty of care is to safeguard their rights in general, including the right to choose. So, you know, I see my role as providing education, providing information, providing my skills, my expertise, talking through with that person, and having them involved in that decision making. Ultimately, that person with the progressive condition is living with the condition. They know they're going to lose function further. They will make that decision, and my role is to support that person to be able to make the decision. Of course, huge caveat, this can get very complicated if somebody has a cognitive impairment or cognitive changes, so it really is important to involve the family and caregivers from the start.
It's a very nuanced role, isn't it?
It is, which is why it's so important to have that relationship with the person where they don't see you as somebody who's removing things. You know, you're not allowed to have these drinks, you're not allowed to have this drink, you're not safe to have that food. That's not my role. It's to support someone ongoing through their journey, and I need the people to be able to talk to me and trust that I'm not just removing.
I definitely think with your accent, when you're breaking bad news, it comes across a lot better than some other accents.
I've never thought about that, hopefully. I have a little slide here on mind your language, and I'm not talking about swearing. I'm talking about the language we use around dysphagia when we're talking about it. And I guess I'd like us just to reflect on how many of us, and I mean us as speech pathologists, use the words, you know, non-compliant. He's non-compliant with recommendations. He's non-compliant with his diet. And just have a little think about the meaning and what that means. It implies that, you know, when we use language like that, we as speech pathologists are removing power and autonomy from the person who's actually living with the disease. You know, it's almost an image of a naughty child, and it's shifting away from that concept of working with the person. They're not doing what I've told them to do. Whereas, you know, really this person is living with the disease, and if they're not cognitively impaired and they're able to make a decision, then, you know, they've made that decision. And for some people, a chest infection is a very small price to pay for enjoying their coffee or their wine or their favorite food, and particularly as they're aware that they don't know how much longer they can actually do that for. And if it's just a chest infection here or there, that's fine. So really just thinking about how we phrase things and how we word things, and how that might subtly influence how we think about our relationships with our patients. Good dysphagia management. So just some general principles, I guess, that we might all already be very familiar with. Some good principles, you know, always do your full swallowing assessment, and also looking at the swallowing assessment in terms of the meal time. So where are they having it, you know, the wider aspect of the meal. It's not just the swallowing of the food. There's a whole lot more to it than that. Obviously, our role is to recommend appropriate diet and fluid consistencies, as we all know. And, you know, I've alluded to some of the complexities or the, you know, more subtle things that we need to think about in a progressive neurological condition. The mode or the method of eating and drinking recommended, you know, we need to think about what's best with this person. Is it a spoon? Is it a nosy cup? Is it, do they really need to feed themselves independently? Do we really need to push that they aren't fed by someone else? Positioning, For some people who have tongue weakness, they might really need to throw their head back to use gravity to assist. Do they need to be in a well-supported chair if they've got significant movement disorders? Do they need, a high back chair with good stability to support their trunk? You need to make sure that their secretions are well managed. If people have excessive thin secretions or excessive, really thick tenacious secretions, that's going to make eating and drinking more uncomfortable as well. So make sure you've got their secretions under control, and just bearing that in mind, that secretion management isn't separate. It impacts on dysphagia as well. In conjunction with the wider team, we have a role around enteral nutrition. If people are having nutrition via the PEG, I see my role very much as reassuring people that just because you have a PEG or you're having some nutrition via the PEG does not mean you stop eating and drinking. My role is to make sure you keep eating and drinking safely and enjoyably. Sometimes people are reluctant to start enteral nutrition for this exact reason, so I like to talk to people about, it's taking you really long, it's taking you ages to finish your meal, you're not getting through your full meal, the PEG can be a top-up, you can still keep eating and drinking. If you've got an OT around, have a chat with them around assistive equipment that can make a big difference, plate guards, specialist cutlery, anything like that, particularly where you want to encourage somebody to continue feeding themselves independently. Often carers think it's quicker just to do it themselves. That's not the aim. We want people to feed themselves as long as they can independently. We speech pathologists have a role around the input into diet supplements, nutrition and hydration. So what are the best kind of consistencies? Often we also have information around what types of foods or tastes or flavors people have a preference for. And then good dysphagia management will also include a little bit around choking management. Okay, so emotional and behavioural support. This is just a bit around, I guess, meal times and supporting meal times and oral intake. So if you can make the physical act of eating easier, that makes eating and drinking and more enjoyable. So that's your liaising with your OT, looking at your cutlery, looking at your environment. Is there something that you can tweak? If somebody has a modified meal, a vitamized meal or a minced and moist meal, I really hate when people mix that all together. The amount of times I've seen carers mix everything together, it just doesn't look appetizing. Describe the meal to the person so they know what they're eating. Eating is a sensory activity. We need to know what we're eating. What is it? Sometimes we can't tell what it is by looking at it if it's modified. So just by describing, saying, oh, we've got some carrots and we've got some, cauliflower with some butter through it, that just adds a whole lot of information that can make things more positive. And our role really is to be positive around the food. No one's going to benefit by us going, oh, what's this? I know we all know it, but it's just good to reiterate. People with progressive neurological diseases with dysphagia need additional time. They do. They just need, everything's a bit slower. Encouragement as well. If it's a hard slog to get the food in, lots of encouragement, lots of prompting, and try and provide some normality around eating. Try and have carers having something to eat at the same time, so it's not just a feeding session, it's a meal time. As I talked about earlier, we sit down communally and eat together. Try and bring that back. Just because someone has a modified diet doesn't mean they have to have a completely different routine around eating. All right.
Fiona, I've got a question here.
Yep.
From Charmaine. What do we tell patients re choking management?
I'll come on to that in a minute. I've got, I think, a little slide. If I don't come to it, come back to you, but I'm fairly sure I've got that further down.
Bart Simpson slide.
Oh yeah, I might talk about that in a bit. But please feel free to prompt me if I don't cover everything you want. The next area that by we I mean we in Bethlehem, we speech pathologists tend to work with and manage is secretions. Secretions being a fancy word for saliva. So we all produce approximately 600 milliliters or more of saliva every day. The function of saliva is, it facilitates taste, it moistens the bolus and aids, your AP transit. It assists speech and lubricates the mouth. It has a role in cleaning our teeth and gums, keeping our mouth healthy, it regulates acidity. That's also that first stage of carbohydrate digestion. You can have impairments with your secretions for a number of reasons. You know, medications can have an impact. People are just dehydrated, they're just not getting enough fluids and not enough hydration. Any changes to, you know, positioning of sleeping, if people are now mouth breathing, or if they're using any aids or BiPAP or non-invasive ventilation, that will have a big impact on their secretions and their mouth positioning and posture, or head and neck control. So if somebody's got really weak neck control and their head is constantly flopping forward, gravity will kick in and result in lots of anterior loss of saliva. Are they positioned well in a chair? Are they well supported? Are they still having oral intake? You know, we know that secretions impact dysphagia, but we also know that if someone's not eating and if they're nil by mouth, this has a negative impact on their secretions. People can often have a reduced spontaneous swallow as well as part of their PND or autonomic dysfunction, as well as anxiety. Anxiety, as we know, impacts our secretion production as well, and with all that people have going on in their lives, anxiety can be a real concern. So I've got two lovely images there. Secretion management is broadly grouped into two sections. We've got excessive thin secretions, which can result in drooling or often a choking sensation as well. If people have a cognitive impairment, we can sometimes see spitting if there's too much excessive thin saliva in the mouth. If you've got too little or it's too dry, we can have, you know, discomfort, dry mouth. You can get a nasty coating in your mouth. It can result in difficulties with chewing and swallowing, and people can also have a choking sensation if they have lots of thick saliva in the back of their throat. If people are presenting with dryness, you know, we kind of branch that into two areas as well: oral dryness or pharyngeal. And pharyngeal dryness can be really uncomfortable for some people. They can have lots of, you know, coughing as they attempt to clear that pharynx of that sticky, tenacious saliva, and that can be really tiring for people. Yeah. The impact of a, you know, impairment in your secretion is obviously your physical function can be impacted. Your speech, if you've got too much saliva in your mouth, you know, that sounds different. Saliva bubbles coming out. If it's too dry, constantly clearing your throat, being uncomfortable with talking, has a big impact on swallowing as well, like we talked about earlier with the dysphagia management. And oral health, if people have too little saliva, it really can affect their oral health and their comfort orally. You know, if people have excessive thin saliva, it can really negatively affect their social participation. People can withdraw and become isolated. They can lose touch with friends. They can drop out of their social activities and their leisure activities. People can, you know, stop participating in groups and taking part in various hobbies, which can then have a significant impact on their emotional well-being. So people can associate this with a loss of independence. They can't, you know, they don't go to the pub anymore to meet their friends because they're concerned about lots of thin drooling saliva coming out. Their self-esteem is really impacted and people can become anxious around that. So their overall general well-being can be really affected by saliva, you know, both their comfort and their quality of life. So that's why it's really important that we do look at and address saliva. So when we're managing people's saliva or secretions, it's important to take a really detailed history, again, from the patient and their carer. And you're going to look at the oral motor assessment. So what is impacting, what might be impacting from an oral motor point of view, their tongue, their lips. Are their lips really weak, unable to achieve a seal? Swallowing assessment, Is their swallow less efficient? Is that why there's a buildup of saliva? Just do a brief review of their oral health and their oral hygiene. You know, if they've had a really dry mouth for a very long time, you could see significant changes to their oral hygiene or their dentition. What medications are they on? That might be affecting things. How's their cognition? Are there changes to their cognition that might affect their insight or awareness, as well as what management strategies they're using. I find it useful to use what I call a secretion chart. Often when we interview people and ask them about their saliva and their secretions, they'll say, yeah, it's a big problem. And I'll say, tell me a bit more about it. What's the problem? And they find it really difficult to identify whether it's thin or thick, how it changes throughout the day, when is it a problem, what makes it worse, what makes it better. So to get a really detailed image of what's actually going on, I often send people away with a chart where they chart throughout the day what their saliva is like at different points. Is it thick? Is it thin? Is it too much, too little? How distressing it is, what they're doing at around that time. So you get a really good picture that really helps you to establish a pattern of what's happening and how this fluctuates throughout the day, because it's very unlikely that they just have a problem that stays the same across the day. And as we know, lots of things such as anxiety, eating and drinking, sleeping, all these kind of things are going to affect your saliva. So you need to have a bit of a picture of what's going on there. And it's also really important to look at the individual's level of distress. You know, somebody might have really excessive secretions but not be bothered by it. Someone might have very minor secretions but find this really, really distressing. So the severity of the impairment doesn't always correlate with the person's level of distress.
And I've got a question from Kate saying, do you have much experience recommending atropine, I might not pronounce that correctly,
yep,
drops or Botox for reducing saliva? And what are the side effects of both?
Yep. So yes is the answer. So both atropine and Botox are used for excessive thin secretions. Botox less so because I think A, it's expensive, and B, it may potentially migrate and affect swallowing. So for that reason, it tends to be something that we don't routinely use. Atropine, yes, I've used. It's short acting, so it's not long standing across the day. So if someone is having excessive thin saliva all day long, it's probably not the best approach. Some people find it very useful for if they're going out socially and they need something to kind of give them a boost for a few hours. Again, you have to be careful with the dosages because I think there's something around potential psychiatric side effects. So it's important to talk to your doctors around any of these.
So does atropine act very quickly?
Yeah, it's a quick acting, locally acting type strategy. So there's some drops that you put under your tongue. I think atropine is actually for something else. I'm not sure what the original use is for. I'm sure someone out there knows, but we use it for secretions, and yet you just use it orally, dries up for a little while, which is why people find it helpful for if they're going out socially, they're going to an event, it kind of gives them a bit of a boost of drying.
And in terms of side effects with atropine, have you found it fairly well tolerated?
Yeah, well tolerated if it's done in conjunction with how the doctor's dosage recommends it. Once or twice people have had some sort of minor psychiatric side effects, so the doctors have suggested that they cease that, but not frequently. So yeah, hope that answers the question. There are other medications that we use for thin secretions, long acting tablets, probanthine or amitriptyline. There is one called glycopyrrolate, which we tend to not use as it's not on the PBS. So key points are lots of medications, key to talk to your doctors. If people are having thick secretions, we tend to use a nebulizer, which is why you've got that lovely picture of the cat with the nebulizer. No side effects really from a saline nebulizer. People can use them as often as they want. There's no dosing issues, but it is important to think about, when, if you suggest someone uses it, when are they going to use it and why are you recommending that time, how often? So targeting it as to when it's needed. And And then there are some dry mouth kind of gels which people are familiar with, biotin and various sprays. Grapeseed oil as well can be helpful. If people are having dry mouths or thick secretions, it's also good to look at their fluid intake. Are they hydrated enough? Are they getting enough?
Do you have any favourites that you like to use?
The nebulizer is a real favourite because it's not really a medication, and so if people have thick secretions, nebulizers can be really good. Most people find benefit from that, so that's a good one for thick secretions. For thin, it depends on what the doctors will work with. So there are some medications that we use more, such as probanthine, which has relatively few side effects, aside from, you know, sometimes people can get excessive drying and it can swing in the opposite direction, so you need to be careful with that.
And Kate's asked another question. She said thank you for the first one.
Welcome.
But she said, do you use dark grape juice for decreasing thick secretions? I think you mentioned it. I think Kate typed it in and you answered it psychically at the same time.
Yes, dark grape juice, absolutely, for people who have thick secretions. Alternatively, pineapple juice can be useful as well. It's becoming a bit of a panacea in that if anyone presents with any sort of secretion issues, we find they've been recommended somewhere to have dark grape juice. It's really just for thick secretions. With managing secretions, really consistency is key. So if you're implementing a strategy, don't do too much at once because you won't know what's working. So identify what the issues are, chart to get a clear picture, and then choose something to address and to target, and give it a few days. You need to really be consistent to know if it's working or not. So if you recommend someone to use a nebulizer 3 times a day because they've got secretions, don't suggest lots of other things at the same time as well. Use a nebulizer. There's no point that person saying, oh, I forgot to use it twice today, I'm going to use it twice before bed. That's not how it works. It's got to be consistent. So yeah. A quick word on choking. So as I talked about earlier, I tend to often build in harm reduction and strategies. When we talk about choking, there's partial occlusion versus full occlusion. So partial is when the airway is not blocked, but there is an inadequate airflow into the lungs. Usually people will be coughing, or they might have a gurgly or wet voice. And for this, we suggest people use possibly an assisted cough if they're unable to clear, nebulizer with secretion related, simply just assisting the person to remain calm and to try and calm their breathing can help the situation as well. Full occlusion is when the airway is blocked, so a person can't speak, can't cry, can't do anything. Generally their hands will go to their neck and you might see cyanosis, so blue lips, blue fingernails. This is a medical emergency. You call 000 in this instance, and then you can try back blows. So I think the recommendations are no longer Heimlich, it's back blows now, which is 5 firm blows with the ball of your hand in a kind of a down and upwards, if that makes sense, motion to the back. So you're hitting in and up to try and dislodge what's there.
And whereabouts on the back do you hit, Fiona?
You really want to kind of middle back, kind of between the shoulder blades, but down. We're lucky in that we've got physios that we work quite closely with as well. I'll just go back. Oh, that slide's gone. I think we're missing some slides, right? That's all right. I find it helpful to suggest to people that they practice the assisted cough. So an assisted cough is a hands-on technique whereby you are, one hand is on the person's sternum and one hand is on their back, and you coordinate it with their breathing, and on the, the assigned count, it can be a count of 3, that person coughs and you also squeeze at the same time. So you're trying to I guess, support the cough, make it stronger to dislodge what's there. We give people hands-on training in association with physios, but I suggest that people practice this before they actually need to use it. So I say to people to go home, try this out, get comfortable using it in a non-crisis situation, so that if a crisis situation occurs, you're not panicking and you know what to do. And I often give people, we've got handouts as well that we give people, so written management on choking strategies. So we've got one side on full occlusion, one side on partial occlusion, a little flow sheet so people can read through that and really be clear, because we can give them a lot of verbal information that's hard to remember. So giving them something to go home with is important, and suggesting that they practice an assisted cough before it's that time to use it. Yeah, okay. All right, which brings us on to speech. The symptom management in progressive neurological conditions. Similar principles in that you're doing a thorough assessment. So motor speech impairments will be seen in most progressive neurological conditions. So you need to know, the type of dysarthria, the intelligibility, the rate of change that you're expecting to see, if there's cognitive change or cognitive change expected as part of this condition will come into it. Have a think about their literacy, or are they of non-English speaking background, and also the literacy of the language of the family and the caregivers as well. So any communication system that we're thinking about needs to be usable by the family and the carers as well. Bearing in mind that things will fluctuate across the day. So as you see a person is not how they will be across that day. So you need to gather the full information. And how are they currently communicating? What are their goals? Who will they be communicating with? For example, you've got, a young man with a high responsibility job in the financial sector and a very young family, versus an older single lady with a very active social life, versus an older gent who just stays at home with his children who care for him, and they speak in Italian. So they will all have different communication goals and different needs. Again, it's a progressive condition. You'll need to be thinking ahead. Just because it's working now does not mean it's always going to work. You don't choose a communication system and leave it. It's an ongoing assessment process. Ongoing, does it meet their needs? Is it easy to use? Function change is going to occur, but also people's goals and priorities might occur as their condition progresses. So they might go from being very sociable to just staying with their family. So that's part of it as well.
Fiona, sorry to interrupt here, but a couple of questions from Kerry, which I think are relevant for everybody. The choking management flowchart, for some reason, we've got it on the handout.
Yeah,
I'm not quite sure why it's not on the presentation. So we will send that out to everybody. So we'll send that as a handout, Kerry, and all the other attendees. And Kerry also asked regarding the handouts, are they available for other practitioners?
Yeah. I have a slide that says at the very end that part of our role is to support other teams, and we work very closely with other teams. So you can call us at any point for any specific questions, and we'd be happy to give information as well. AAC, there's a huge and wide spectrum of options for AAC, ranging from the no tech gesture all the way up to the very high-tech eye gaze. There's too many options for me to talk about. I can't list them all, but the principles really are that fancier and high-tech does not always mean better. It's about what the individual needs. Some people are fantastically happy with a pen and paper or an electronic writing board. Some people really want and work well with high-tech. So it's about what that person needs, what are their goals, and what's going to meet their needs. And we don't expect everyone to know all of the options that are available. There is a service, Comtech. We also have a large bank of electronic devices. It's important to keep in mind someone's cognitive function, someone's language and literacy function when you're thinking about AAC, and also preempting the changes that are going to occur as well. I always talk to people, that I don't have a miracle cure, but there are lots of different options, and that there's no just one answer. Different strategies or different AAC methods might be beneficial at different times throughout the day. Voice bank and message banking is an emerging area that people are asking about. So it's just important to remember that the individual needs to have a really good level of speech to be able to participate in that. For AAC, remember that it's not just for face-to-face. We've had people who need to communicate via Skype. If the effort that somebody needs to put into using a method is greater than the outcome, then it's generally not going to be effective. So that might explain why some people have their devices locked in cupboards. And I always talk to people about that nothing is ever going to be as good as or efficient as your own speech, and acknowledging that is really important. And I think that explains why people tend to persist with their speech even when it's incredibly dysarthric. People with progressive neurological conditions are going through a lot of change in a lot of areas of their life. So just because I think a device is great and is going to be really helpful for them doesn't mean that the person thinks the same thing. Just because I think their speech is terrible and a priority doesn't mean the person thinks it's the same thing. So we have to know where they're at. Are they ready to accept change? Do they want a device? Do they want an electronic device? Do they not want an electronic device? Are they more concerned about something else, such as they're walking and they just aren't in the headspace to think about their communication at the moment? Okay. This is the final little topic, which is the challenges of facing speech pathologists in progressive neurological conditions. And I think it's just, I might waffle on here a bit, so feel free to hurry me up. But clinicians, and not just speech pathologists, but clinicians in general who care for really ill patients face a high risk for reduced and diminished personal well-being, including experiencing issues with burnout, moral distress, and compassion fatigue. So burnout is defined as a progressive loss of idealism, energy, and purpose experienced by people in the helping professions as a result of their conditions of their work. Moral distress is the inability to act in a manner consistent with one's personal and professional values due to the institutional and other external constraints. And compassion fatigue is defined as diminished emotional energy needed to care for patients. And stress and burnout are closely related, but the terms aren't actually interchangeable, and the difference being that stress goes away when the cause is removed, but burnout doesn't shift. And there are a number of very real and significant physical and mental symptoms that these conditions can produce and can really affect our health, our sleep, depersonalization of patients, and ultimately potentially providing suboptimal care. So it's really important to be aware of this and to look after ourselves. The key characteristics of burnout are physical and emotional exhaustion, cynicism, and inefficacy. And the characteristics that are more likely to predispose clinicians to burnout are, interestingly, being female, working in a solo practice, being early on in your career, lacking a sense of personal control over events, and if you attribute your success to chance instead of your own personal accomplishments. So I think it's important for us to be aware and alert to this as a very real issue.
We did a webinar on self-care, in recognising this in particular, Fiona. So just want to flag with people listening that you can go to the MS shop and get a recording of that with some wonderful tips.
That's really helpful, some of the tips that we talk about in taking care of yourself and professional self-care, which is obviously so important to be able to provide care to the patients, is setting appropriate professional boundaries, knowing where that line is. And we all as carers want to go above and beyond, but at some point there needs to be a line. Regular supervision and appraisal of all aspects of work is really important. It gives you that time to debrief. It also gives you a set of fresh eyes kind of going, I notice you're not as enthusiastic about this, or I notice you're not putting as much time into that. And that can really help us to refocus on what's going on, because sometimes we might not notice if we're experiencing compassion fatigue or burnout. Have a network of peers and mentors who understand there's no point going home and talking to your partner or your mom or your family and they just don't get it. That's not going to help. Try and find engagement opportunities in your organization as well, and try and improve your communication skills, rather than just sitting with it, talking to someone about it. Identifying and preventing burnout really are important.
A really good question coming here, Kate, Fiona. It's not relating to self-care, but it's really worth ask, and it's from Kate, and it said, given the time it can take to have AAC devices approved from insurers, e.g. NDIS, how would you manage a patient who may decline AAC as they prefer speech because of cost, when you think it's going to be needed in the near future? It may be too late to order AAC by the time they're open to it.
Hang on, I'm going to need to hear that again. That's very long.
Given the time it can take to have AAC devices approved, how would you manage a patient if they decline AAC because they want to continue with their speech? And then when you think it's going to be needed in the near future, it may be too late to order it by the time they're open to it. So it's almost like, can you order it preemptively, I think.
Well, if you're thinking about the device, I guess it means that they do need it, whether they're ready for it or not. If you think that timing is going to be an issue, how I would go about it would be to say, absolutely, you want to keep using your speech. That's fine. I fully understand and support that. However, we all know what the system's like. It's going to take ages to get. If we put the order in now, it might come in a couple of months down the track. You can try it out and see it. And if you don't want to use it, then that's fine. So I think it's about validating that, yes, that person wants to continue using their speech. That's fine. It's about presenting it in a way that you're working with them against the challenges that are there. It's an option. It's not the answer. We need to get it, now, because otherwise, blah, blah, blah. You know what it's like bureaucracy, paperwork takes for ages. It might be harder to get it down the track. It's better to have it now and not need it than to not have it when you do need it. If when you get it, you decide you don't like it and it's definitely not for you and you've given it a good go, we can always return it. That's not an issue. So, working with the person, allowing them to continue using their speech and kind of, I guess, cajoling them into, not gaming the system, but that's how it's going to come across to the person.
I think the idea that you don't have to use it if you don't like it, you can try it, that gives a nice committed approach, doesn't it?
Yes, and it's all about, exactly. And I never say this is the device for you. I think it might be great. The amount of times I have given someone or shown someone a device and gone, this is going to be fantastic, and they hate it and they don't use it. You never know how someone's going to respond to a device for whatever reason. So that's why it's really important to try, and that's why I present things as we're coming together to have a go at this. Let's have a look. It's one of the options. There are many options. And one of the points that I actually forgot to make that I'm going to come back to is with AAC, if you're looking at high-tech options and if you're looking at something electronic, it's really important if you go down this route to also have something low-tech, to have something simple as a backup. As we know, computers break down, they crash, someone drops the iPad, it doesn't work for some reason, and you can't have someone with no way of communicating. So we need to make sure that there's a low-tech, I like to use the word rapid access instead of low-tech. It's a bit less, simplistic, and making sure that that's always there in the event of something happening with the high-tech. The other point with high-tech is if you're considering that, make sure the person has support to use that. There's no point having someone with a really fancy device that no one around them can use and no one around them can troubleshoot or solve any issues when they arise. So if you're thinking about a device, you need to make sure that the support is there to use it and provide education to the person and their family. I think we're out of time. The last bit, like I said, is feel free to give us a ring. We'll help if we can on anything progressive neurological related. That's part of the service we provide. Thank you for listening if you're still with us and you're still awake. Any other quick questions before we have to finish up?
I wonder, have you got the telephone number, Fiona, or email contact for people who might want to email to get the choking handout? That would be really helpful.
I might send, because I don't know the general email off the top of my head, I'll send the handout to Nicola and she will disseminate it. Our speech pathology department number is 95953327. That's 95953327.
I'm just going to send that to everybody.
Okay.
So, okay. I'll send that out to everybody with their handout. And I've just got a couple of brief questions. So, acknowledging that we are at 3 o'clock, if people do need to leave now, then thank you very much for your attention. There are a couple of really good questions which I think you might benefit from hearing. So I'm going to run these past Fiona as well. So, and we've had quite a few thank yous come in as well, Fiona.
Oh, very welcome.
Here I've got, sorry. Let me just pull these questions out where I can actually see them. Excuse me. Sorry, I've addressed that one. Actually, I think we've done it. I thought there were questions, but we've already covered them. So
great.
We're good.
Lovely.
So all that remains, I just want to thank Fiona very much. I think one of the key things that I have benefited from is hearing all the technical and clinical skills that are entailed, but also the wonderful examples, Fiona, that you've given us on how to communicate in very difficult territory, which I'm sure many of the people listening will have found really, really helpful. And again, Rosie, Kerry, Christine and Kate, they've all sent thank yous through for you. And I just want to give a little bit of information about the services here at MS. So we provide a variety of services for the people that you're managing and working with. Everything from obviously education. There's a huge amount of client webinars available on our library. We provide peer support. We provide employment support. We provide volunteers to work with your clients, whether it's to help them technically or to walk their dog or to take them shopping or to have a cup of tea with them. So lots of support. And then we provide MS Connect, where your clients can speak to a nurse advisor, can speak to a social worker, can speak to a continence nurse, etc. So please do use our services. The MS Practice is an online education series which you can access via the link on that slide. We are an NDIS provider, and these are the services that we provide in the various locations around Australia. We're providing a lot of support coordination, and from your client's perspective as well, we provide a lot of support around planning for their planning conversations, which is really important as we try to ensure that they get the kind of plan that they want in a timely fashion. There's ebooks available to you all, and there's your login and password. The MS Shop, you can look at webinar recordings. And a big thank you from us for your attention and your commitment to keep improving your practice for people who've got progressive neurologicals. Here's our MS Connect number, and that is the gateway to our services. Please feel free to use that for yourselves and also to pass on to your clients. So thank you again very much for your time.
Can I just make one brief point before we finish? There's one slide that I didn't talk to called the challenges facing SPs and PND, what are the must-haves. Just want to reassure people that was just a synopsis of everything that I've talked about in the general talk, so there was nothing that was missed.
Great, and you can always contact us, and Fiona's contactable through Calvary Care. I'll pass her information on, so it's part of an ongoing conversation, I'm sure. So thanks again for your time.